are, older. So why is that? Of course, there are many different reasons. And in 2018, actually, Heart and Stroke Canada came up with a very interesting document, and it's available for free. You can Google it. They called it the Misunderstood. So women and cardiovascular disease is under researched, because until 2016, actually, it wasn't even mandatory to include women in research and have the same thing. So they just assumed that women were smaller men, which is not true. So that is one. And it is under supported, which is very sad. And it is also under recognized in some conditions. But the part that, Natasha, you and I probably have more expertise in dealing with is the part where under awareness. So a lot of women don't know what their, risk for heart disease or stroke or any of this is. So most of the time when we talk about, heart disease or stroke, it's like, oh, being overweight, being a smoker, and, high cholesterol, and, diabetes. Yes, these are the top four. And the fifth one they've added now is sedentariness. But what if a woman doesn't have these four or five? What about those risk factors that a lot of women are not aware of? And one of the major risk factors which women are aware of, but probably don't take adequate action, is hypertension. So, Natasha,
Right.
add a few words about hypertension and why it is so dangerous, and why women don't, not only women, well, it includes me as well. A lot of people are not aware of what is going on with their blood pressure.
Yeah, I just want to interrupt you there for a moment, Shabnam, because I just have to tell you, before functional medicine came into my life, and I remember I just moved to Canada. This was 1998, so a long time ago. And I was working in the emergency department, and I had a patient, a female patient. She was 50. Now, when I'm in my 20s, of course, 50 seems old. Today, 50 is just a year away and a little bit for me, right? And I think, oh my God, that's so young, right?
Oh, yeah. I don't feel old. I'm way past
Yeah, yeah.
50.
Well, I feel young all the time. So thank God for functional medicine. In fact, I just had a rep yesterday tell me that over the last 7 years, every time she sees me, I'm younger and younger. And I said, it's not the power of aesthetics, it's the power of functional medicine. But anyway, back to Shirley in 1998. She had presented to the emergency department 3 days in a row, and she had burping and epigastric pain is that pain right below your sternum, and it feels like more like an ulcer type thing, right? So she kept getting treated for digestive issues and came back. And I didn't know that women were not small men back then, and she had nothing to point to heart disease. And I am not sure why. I don't know if it was because she was a little sweaty or she just didn't look well. I ran an ECG and she had the changes of a heart attack. Now, it occurred to me that something was really odd because she didn't present like that, but I had no information or training or anything about it. But I will tell you one thing. She ended up never being the same person again, because she was a family practice patient of mine in the office, and then I did emergency medicine as well, right? And her life was never the same again. She was fatigued, she was depressed, she ended up on antidepressants. I know you have something to say about that today. She just was on so many medications, had so many side effects, but her level of functioning, her mood and her personality and who she was never the same again. And with 50 being young, I wish I knew what had happened eventually, because I mean I left there after 7 years or 6 years, right? But it's so sad. And then post functional medicine, and this is maybe a little bit out there, and maybe we don't want to quite get into the details of this today because we've got 3 more episodes coming up. But I had a patient, and I was in this little town about 2 hours outside of Calgary. And this lady, same kind of story, coming to the ER every day, having odd kinds of, but she had a little bit of chest pain sort of thing. But her blood tests were normal, her ECGs were normal, everything was really good with her. Excepting that as I talked to her, I'd remembered in a functional medicine module on cardiovascular disease, they were talking about how women get spasm of the microvessels in their heart, and it's not actually a blockage, and it's not actually classical heart attack. But so I called up the cardiologist, and I'll tell you something, I've met some cardiologists who are very dismissive of everything I say, but this one was actually like, I just read something about that too, and I think you should send her to me. He called me up the next day and confirmed that she absolutely had this microvessel spasm, and it's particularly in women and often missed.
Yes, and Natasha, you brought this up. It's such an important and valid point. See, up to 92% of people, and this is, I'm quoting studies, experience warning signs. And the sad thing is, it's not just, the doctors sending them home by telling them you just got indigestion. It's also women themselves who ignore these. So yes, most women would present with chest pain. About 60 to 70% would have chest pain. But there are all these other symptoms that women sometimes ignore. It's like shortness of breath, dizziness, nausea, cold sweats, loss of appetite, overwhelming weakness, fatigue, pain in the jaw. So, so many women have
indigestion, heartburn,
absolutely.
burping, pain in the back, like in the middle of your back, pain in the shoulder.
So many women do not experience chest pain, and if any of you have, so this is the our attempt at making you aware. If you have any of these symptoms, please do not wait at home and say, okay, I'm just going to take a few deep breaths, it's probably all stress. Very often women are dismissed at, it's just anxiety, it's just your depression, or it's like the catch all is like stress. Who is not stressed? But my suggestion would be, please do not ignore these symptoms. They see, if you go to the ER and you find out you're not having a heart attack, that's wonderful. But please do not wait at home. So the sad thing is, many of them have been dismissed as indigestion, and then they had to go back again when they had classical symptoms. So that is the sad thing. And then going back to hypertension, why I brought up is, hypertension is one condition which very often has no symptoms. So that is the reason most people don't measure. And so, Natasha, did you want to add something to, because now you're very often in the ER. So what happens? Like, what would be a hypertensive emergency that you would sometimes see?
Well, here's the funny thing. It's amazing how many people will say to me, I know my blood pressure is high, or I know it's normal based on how I feel.
Yeah.
And inside of my inside voice goes, how exactly without a monitor do you know this?
Yeah.
Right? On the flip side, being the doctor that I am today, who is not the doctor I was when I graduated 26 years ago or 25 years ago or whatever. Back then it was what we say goes, what we know goes, and you don't know anything and I know everything. So if it's not a symptom I've heard of, then you're wrong and I'm right. And today I tell patients, it's your body, you live in it. So you know when it's not right, you know when it's not well.
Yeah.
Right. But it's fascinating how many women will tell me, I know my blood pressure is high, or I know it's low, or it's fine, or whatever. And I still say you have to test it. The
Yeah.
best test I find, and in our practice here, this, we send everyone for 24-hour ambulatory blood pressure monitoring, because that is the only way to know. And it sorts out those dippers and the non-dippers. And I want you to say something about that
Yes.
next.
Thank you, Natasha. I was going to pause you because
Yes,
someone's
but
not
you're
done
saying
that.
in the ER, how do people present? Now, regular hypertension is a definite risk factor for vessel disease. So whether it's in your brain and you're going to get a stroke, or in your heart and you're going to get a heart attack, it is a risk factor. However, when you're talking about hypertensive emergencies, I don't even think I want to go there because it's such a complicated and long story. And today we're talking about women and their unknown risk. And don't think that men can present classically. A lot of men have pre-diabetes and diabetes that is not diagnosed, and you also don't present classically. And I can tell you that the majority of people I treat for heart attacks in the ER do not show up with classical, I mean, they do, but not all of them show up with this elephant sitting on my chest and the pain's going to my shoulder and then it's going up to my jaw and I can't breathe. I wish that everybody showed up like that. But you'd be surprised at how many people do not show up like that. And diabetes is a huge confounding thing because diabetics do not present classically. So just because we're talking about women who do not present classically, this doesn't exclude men because many of them do not present classically. But a hypertensive emergency means we're going to have some catastrophic outcome from a very high blood pressure. You're at risk for a stroke. You're at risk for a heart attack. You're at risk for your kidneys getting damaged. There's so many things, right? But that's not what we're talking about. By the time you get to a point of having a hypertensive emergency, you have missed the boat.
Yes.
You should have been 5-10 years ago been diagnosed with a 24-hour ambulatory blood pressure monitor if it wasn't picked up in the office. And a lot of people will say, no, my blood pressure is only high because I'm in your office. It is normal at home. And I go, you know what? The fact is, it is high. And that's a problem. Because if you didn't have hypertension, then it wouldn't be high regardless of where you are.
Yeah.
So that it can go high and really high, stop dismissing it and discounting it. And I just want to say this out loud on this webcast. Shabnam, I don't know why so many people are absolutely willing to dismiss these things and they just don't want to acknowledge that maybe I have a problem.
I don't know why, because, and again, I think basically it's because hypertension, as you said, the point in, why I brought up, emergencies is don't wait for that stroke, you will not know you have hypertension until you measure, number one.
Right.
So if you have an instrument at home, measuring once will not tell you. There is a way to do a home monitoring. And if you are Dr. Iyer's patient or my patient from India, no one from India has joined in, it's like middle of the night. We do a 24-hour ambulatory blood pressure monitoring. So if you're Dr. Iyer's patient, you know that you refer to the cardiologist. What you do essentially is you wear a blood pressure monitor for 24 hours. So every 15 minutes, 20 minutes, it's kind of irritating at night. It inflates and deflates the blood pressure cuff. And then you take the machine back to the office and then they do an analysis of your blood pressure. So blood pressure recordings at night, you cannot get that by doing a home monitoring. And that is the reason we talk about, doing a 24-hour ambulatory blood pressure monitoring. And by the way, this is not something functional medicine doctors have come up with. This is from classical cardiology. So what they have found in recent years is women and men who do not have a blood pressure fall at night, they are at a higher risk for heart disease, stroke, and all of this. Even if, the rest of the time they've gone to the doctor's clinic and the doctor said your blood pressure is normal. That is one thing. Another thing is, many people are probably not aware that in 2017, what is normal blood pressure? The numbers changed. So it's 120 by 80. It is not 130 by 85. It is definitely not 140 by 90. So that is the other thing. And
I have this argument with patients in in my office, people know functional medicine, our tolerance for abnormal is not there at all. We want normal, we want perfect, we want optimal. So slightly high, borderline high doesn't exist. No. You have to be optimal for a sort of useful level for healthy aging and longevity, right? Yes. But I still have patients coming in at 148, 140, 150. And they'll tell me, no, my doctor said it's just slightly high because, 140, 90. I'm like, 140, 90 if you want to get disease. But in functional medicine, we have our patients wanting to live disability and disease free. You cannot live disability and disease free for the rest of your life if you tolerate upper end and a sort of just above the high end. So nothing there is tolerable. So if you use 140 on 90, which for us is unacceptable, then 145 on 95 is not acceptable either. 150 on 95 or 100, still very unacceptable. That is extremely high. So in our world, and the data is changing, the societies that come up with guidelines are even saying lower is better.
This is very interesting, Natasha. And I always say, because we are in functional medicine, we have a whole lot more tools in our toolkit. Because when we talk about, someone's blood pressure being 140 over 90, are we necessarily looking at, adding one more antihypertensive medication? No. Our first approach, and again, I'm not saying if you are on antihypertensive medication, you should stop them. No, many of you will need to be on them. That this is not medical advice. But my point is, if someone's blood pressure is 140 over 90, and they're taking the medication regularly, you and I are going to have this conversation about, okay, what else can we do to get your blood pressure down? So what are the other things? And this is where, we in the functional medicine world have a lot of advantage, because I'm not choosing between two potentially toxic drug, like this is less toxic and this is more toxic. No, I have a lot more other stuff. So one of the things is, of course, weight loss. And this is not even, so Natasha, one thing, I don't know, I'm sure you found this as well, because people think that if they have, let us say they are overweight by, and again, overweight by in their parameters by, let us say 30 pounds. Now, the interesting thing is even moderate weight loss. So you have not achieved the ideal figure that you want, but if you've just lost 5 to 10% of your body weight, that has a huge impact on blood pressure. Yes, you have
Yes.
not reached the kind of on a weight you want to be at, but does it mean you've not achieved anything? No.
And so that and that is a whole different. We should do a separate thing on weight
Yeah.
loss and weight and what ideal weight is, because I had a patient say to me, "Why can't you be healthy if your weight is up? If you can run a marathon and you can do this and you can do that, why is it that you think I should lose weight?" So I don't even want to go there. But exactly what you're saying. Some people want to lose weight to look a certain way. We're not talking about the aesthetics. We're not talking about all of that stuff. We're just saying that if you carry extra body weight, your blood pressure will be higher, and reducing it by 5 to 10% can lower your blood pressure enough to be in a healthier range. Now we're coming to the end of our time together, Dr. Carr. So what are your last things? So this is the first part of a series of 4 talking about heart disease risk. I think the next 3, we're not going to limit it to women only. We're going to broaden it, because I do see a lot of men on my Facebook Live even right
Okay.
now. And I am bringing them into the conversation, because weight loss, activity, not being sedentary, alcohol, lowering your alcohol consumption can lower your blood pressure. Not smoking stopping smoking can lower your blood pressure. Stress and stress management, because when you're stressed, natural instinct, that is evolutionary, your blood pressure will go up when you're stressed.
Another big one is sleep. So it's wonderful that we have a lot of men in the audience, because I'm sure they all have women in their lives. But as a former OBGY, one of the biggest shocks in Natasha, I felt so ignorant, I can't tell you. Until
Yeah.
a few years ago, I had no idea that if a woman had preeclampsia, that means hypertension in pregnancy, or pregnancy diabetes, and these are not small risks. Like this is like 300, 400 times higher risk of having hypertension, heart disease, and all these. And then there is, of course, an entire world of young women immediately after delivery having, chest pain. And that is, again, a lot of interesting work going on. So bottom line, women have some unique risk factors. Another big one is autoimmune diseases. Then, of course, in subsequent ones, we'll of course talk about hormones. How can we not talk about hormones, Natasha?
Yeah, but men have hormones too.
Oh, yeah.
So you were saying something interesting to me when we were talking earlier on the phone, Dr. Carr, and I just would like you to say something before we conclude about pregnancy and childbirth as risk factors for. I have 2 kids. Should I be worried?
Well, I don't, I don't know your obstetric history. So if you had pregnancy hypertension, if you had pregnancy diabetes, if you have a history of stillbirth before, or if you've delivered a baby which is small for the age, or you're someone who's gone through fertility treatment which was not successful, all those factors place you at a higher risk for cardiovascular disease. Another big one is PCOS, and today we don't have time to cover all of that. And
Polycystic ovarian syndrome,
yes,
PCOS.
PCOS is polycystic ovarian syndrome. So that is again a risk factor for entire life. It's not just in the young age and infertility in the
Mm.
reproductive age group, even in older women. The other thing is, depression is a very high risk factor for cardiovascular disease, more in women than in men. And diabetes is the other interesting one because diabetes is a much higher risk factor for women than men. And interestingly, if you had pregnancy diabetes and you didn't develop diabetes in the next 5 to 10 years, even then your risk is high. So it's like there's no escape.
So now we're talking about having a risk. So all of these people watching us and joining us and taking time to educate themselves, so they have this increased risk. What are they going to say to their doctor?
Mm, interesting. Because depends on who the doctor is. If it's you or me, we know what to do. So today I was actually on the Canadian Women and Heart Disease conference, and it was online. So they were talking about how can you talk to your doctor about, because obviously in a regular family practice, it's not possible for a doctor to invest a lot of time the way we do. We talk about. So they were talking about shared decision making. So that was interesting because you and I think, at least I think we do it already. So, what are the things you can do for yourself? Number one is check your blood pressure regularly. If you check morning, evening for at least 1 week or about 10 days, and you go and show those numbers to your doctor, and they are not normal, then definitely your doctor will tell you what to do. The other thing is daily step count. So, if you are using a wearable, you will know that, avoid continuous sitting is another thing I'd recommend. And of course, we can talk about so many things. You talked about stress. So there are a lot of things that you can do yourself, without necessarily going to the doctor. And more importantly, if you are on a medication, are you regularly taking it? You know, Sleep is another big one. You need to prioritize sleep. There are two kinds of problem with sleep. One is chronic insomnia. The other one is you don't think sleep is important for you. If you are in that group, and Natasha, you might be. If
I
you
work in the emergency department. I don't have a
No, that
choice.
is excluded. So if you're someone who thinks that sleep is not important for you, I am
I
very
used to, honest
thankful.
to goodness, Shabnam, until all this data on sleep came out, I would not sleep more than 6, maybe 7 hours a night because I thought there's so much to do in my life and I just don't want to waste my time sleeping. I'll sleep when I'm dead, like I'll just sleep when I'm dead. That's okay. And I do prioritize sleep, as you know now. I
Yeah,
obsess about
I
it.
know
I
that.
wear a wearable. I do all of that. But what would be interesting is to close on this other note when we're saying, go to your doctor, talk to them, and all of this. But I will leave you hanging with this thought. More than half the people who show up in the emergency departments, not just mine, but
Mhm.
all of them, so everyone in the world who shows up having a heart attack tend to, like, more than half the people have normal cholesterol. So it begs the question, what else other than cholesterol? And yet you talk to any doctor, any cardiologist, they're obsessing about LDL and LDL numbers, and it's got to be below this number, and you have to put statins in the drinking water, and we have to lower cholesterol. And I always just go, oh my God, like, what are you missing? So, like, the data is so clear that more than half the people who have heart attacks have normal cholesterol. And the flip side, how many people in their 70s and 80s are walking around with high cholesterol and they have no heart disease?
No, neither dementia, some of them. So interestingly, what is this, the sad part of this whole story, Natasha, is, and both of us are not recommending you should get off your statin medication or anything like
Absolutely
that.
not.
But uh, some people think that if they're taking a statin medication, then they don't need to do the lifestyle modifications. No, no,
That's
no.
right.
That
So,
is the
in
sad part.
conclusion, in conclusion, you still have to do the work. It is still up to you to make changes in your lifestyle to improve your health. A pill is not going to sort all your problems out and solve everything so you can continue to sit on the couch and not get your steps and change how you're eating and all of that. So that being said, maybe in the next webinar, we're going to talk about cholesterol a little bit more. We're going to talk about advanced cholesterol testing. We're going to talk about probably some omega index information, because that's cutting edge and people should know about this. And then I think if we have time and we don't go on like we usually do, cover off on a couple of key nutrients that people can add to improve all of this. So
Oh,
that's what we'll talk about next week.
absolutely.
Stay tuned. I'm hoping we do it on Monday.
Okay, we have a message from one of our participants on the webinar, and this is my response to you. Yes, we will use your, she wanted us to share her story as an example. We'll do that next time.
Wendy?
Yeah. Okay. I didn't want
Thank you, Wendy. I meant to ask you today, but we missed our appointment. So I was going to ask you if that would be okay, because we predicted you were at high risk for heart disease and no one believed us, not even your doctors or the cardiologists, until it happened, right? So thank you for that. We will add you to the webinar on Monday, and maybe we'll just get you to say, send us something to say on your behalf. So then, Wendy, you must stay for the next three webinars, because when we're covering hormones, you had a lot of questions about hormones and their safety and all of that, and does it increase your risk, because that's what your cardiologists are telling you. And here we are saying absolutely not, you need them. Okay, so thanks again, Wendy, and thank you all for joining us. We will see you on Monday.
Thank you very much, and happy, healthy heart and brain. The other thing I wanted to say is it's not just the heart. We think of the heart and brain together. So
yes,
I
what
know.
affects your heart affects your brain. What's affecting your brain is affecting your heart. And that's where this whole omega story comes in. Hey, all right, you all. Thank you so much for your time. Take care. Bye
I
now.
know.